Hi there. Thanks for joining us. I'm Julie Kenville, president of the MUHC Foundation. Each week, I will take you behind the scenes with leading experts to discuss today's most pressing healthcare issues and to find out how we are changing the course of medicine and lives here in Montreal. Today, we are exploring the impact of technology in healthcare. Technology is fast changing, especially in medicine. We're hearing as patients a lot about the disruption of artificial intelligence, and we're seeing a lot more high-tech equipment in the hospitals. Today, two MUHC physicians will help us understand. Dr. Gerry Fried is former surgeon-in-chief at the MUHC. Dr. Abhinav Sharma is a cardiologist specialized in advanced heart failure. Thank you so much for joining us today. Dr. Fried, before we get started talking about technology, I do want to congratulate you on being the first Canadian ever elected chair of the American Society of Surgeons. Can you tell us what that means for you and how you felt about that nomination?
Well, thanks, Julie. It was an enormous honor, both on my behalf, but on behalf of the MUHC and McGill that I represent. The American College of Surgeons is the largest surgical organization in the English-speaking world, with about 90,000 members representing surgeons in all specialties. The opportunity here is to really have an impact and to scale my ideas so that they could have influence internationally, impacting education, impacting quality and safety, and really the practice of surgery as we move forward. So it's great. I think it's wonderful for Canada to be recognized in this way. And I owe the opportunity really to my home, which is here at the MUHC.
Now, you're a pioneer of minimally invasive surgery, and I love the story about how you got started in this area as a young surgeon. Can you tell us a little bit about what brought you there and how you managed to develop new technology?
The development of change in medicine is not gradual and incremental. It's big steps. And if you think about things like heart transplant or joint replacement or things like that, they occur suddenly. One day you can't do it, the next day you've changed the world. I was lucky that in the late 1980s, we had a visitor from Germany that was here in Montreal visiting McGill, and I had the opportunity to meet him over lunch. And he was telling me about this new operation that he was doing called Laparoscopic Cholecystectomy, minimally invasive gallbladder surgery. And he said, this is going to change the practice of surgery. Why don't you come to Germany, spend a week with me in my home, and this will make you a famous surgeon one day. So
and he was right.
I went home, I told my wife I'm going to Germany, and I spent a week with Dr. Treudel there. I watched them do this operation. I came back, I went to the foundation, and I said, we need to get into this. They bought the equipment, we were up and running, and really the first, I believe, in Canada to start offering our community this operation. And from there, we asked ourselves, how can we take this technology, utilize this for other procedures? And we had the opportunity to grow and grow, develop the methods to train people differently, developed simulation as a means for training surgeons like pilots, and the field just went on from there.
And how did you fund all this discovery?
The funding for this was through philanthropy. The healthcare system in Quebec is terrific, but it provides the base. And when you want to get into innovation to try to get into something that is not yet proven, something that's new, if you want to be ahead of the curve, then that's where the foundation supported us. I think the opportunity of the community through the foundation to have the vision to provide funding for these types of things has been invaluable, and it has worked that way throughout my career.
Is this standard in hospitals across Canada and the United States that you want to be ahead of the curve in medicine, or is this restricted to McGill?
I believe that one of the responsibilities of an academic healthcare institution, like a teaching institution such as the MUHC, is not only to provide the highest quality of care, but to define the future of healthcare through research, to train the next generation of physicians through novel educational programs, and then to scale that by training the rest of the wider community to provide that type of care in a more extensive fashion. I believe that there is no institution that I know of in Canada that does this better than the MUHC, that has that vision, that that thought in their DNA, that value system that we have. I'm sure there are many places in the States, and there's some places in Europe and elsewhere that have a similar thought process. But I really do believe that we are way ahead of the curve at the MUHC, and I'm proud to be here. And that's why I'm here, to tell you the truth.
And thank goodness you've decided to stay in Montreal. I'm sure that you were highly sought after and recruited. And I'd love to speak to you a little later on about the future of the operating room and what are some of those new technologies that are underway. But before we do that, Dr. Sharma, you were highly sought after. You came into McGill and the MUHC about a year ago. And why did you choose Montreal?
So thank you very much, Julie, for having me here today. So with regards to why I chose Montreal, as I was leaving my fellowship, it was critical for me to go to a place that really supports young investigators and young researchers. I knew throughout my training at various institutions in Canada and in the US that the first several years after fellowship are very critical with regards to developing a line of research that's novel, that's innovative, that has the support of an institution, and the freedom to explore and actually conduct some of those research, that sort of line of research. Now, a lot of my own work focused around the intersection of cardiovascular care and digital health. And so the institution that I wanted to go to would have been a place that understood that vision and the need to integrate digital health with healthcare delivery. And the MUHC was really one of the only places that sort of understood that vision and that recognized that this was the future. And through funding from the foundation, we were able to get a program started, and the results of that are now coming to fruit even in this early period.
Can you tell us what is digital health? It doesn't mean anything to me as a patient.
So digital health really is a broad spectrum. It's an umbrella term that identifies the use of novel technologies to augment or to accelerate healthcare delivery. This can mean anything from wearables such as watches or wearable technologies in clothes, all the way to algorithms in computers, all the way to new diagnostics such as instruments or other such technologies. So digital health is really a catch-all term. What we are really focusing on is how can we use these technologies to improve patient experience, patient care, and improve the health of Canadians.
Now, you recently received a very large donation from John Carswell and Canso, actually based out of Ontario, interestingly enough. And can you tell us about the projects that you are able to build thanks to this contribution?
Yeah, so the two big fields that digital health can really apply is our ability to follow patients when they are not within the healthcare environment, and to also use technology to optimize healthcare and healthy behaviors. And so this is where some of this funding has really allowed us to really improve these elements. So the first is our ability to follow patients when they're not in the healthcare environment. I think this is critical, especially now that we're recognizing in the time of this pandemic, where we need to offer care not just in the hospital or in a clinic, but in someone's home. So we have now developed prototypes where we're using voice-based technologies, such as Amazon Alexa, to be able to track patient symptoms, to be able to screen for symptoms. And now, for example, with COVID, we're testing the use of Amazon Alexa to screen for COVID symptoms. So this important foundational work allows us to prove that this technology is feasible and usable, and that participants and patients like interacting with it. The other way that this funding is being used is to actually create applications to encourage people to move more and to allow them to improve their physical activity in their own home. So this is where some of the advances are happening with digital health and digital technologies.
Dr. Sharma, the pandemic did force us to accelerate some of the discoveries, and you had the opportunity to test one of your projects, the Alexa project. What were the results of that?
Yeah, so the Alexa project was able to launch due to funding opportunities from the foundation. Alexa is essentially a voice-based assistant, which is currently being used in people's homes as a tool to help in their day-to-day life. So to set reminders, to turn lights on and off, to turn the radio on and off. So it's been used as a part of people's lives in their home setting. The idea was, could this Alexa device be used to actually help healthcare providers screen for symptoms of various diseases, in addition to identify when a patient may be worsening with regard to their underlying health condition, and to track this when people are not in a healthcare environment, but actually in their home setting. And I think this is very critical because as we look forward, healthcare delivery is going to happen more and more outside of the walls of the hospital and in the homes of the patient, where people live and in their natural environment. And so with this particular project, we were initially developing an Alexa skill, that we call it, to identify patients with heart failure. So those who have very weak hearts that are not able to pump effectively, we wanted to see, can we identify when these individuals are worsening? Now, one of the big issues is that people can worsen very quickly, and they often end up in the emergency room, and it's the #1 cause of hospitalization in people above the age of 60. So we were hoping to use the Alexa to track symptoms. Now the pandemic started, and as a result, we decided to pivot slightly to use the Alexa device to actually screen for COVID-19 symptoms. The study is currently actually ongoing, and if you come to our mezzanine, you could try to hear in person. But what we found so far is very encouraging, that the use of a voice-based technology can effectively screen individuals for COVID-19 symptoms. Most patients are happy to use it. They actually like the fact that they can interact with this device, and it provides a way so that we can screen individuals without having to have people stand there to prevent the transfer of this virus. So we're really encouraged by our preliminary results, and once we have these results, we'll be publishing them fairly soon.
But are we using technology to replace human interaction? That doesn't sound very positive for our patients.
No, that's a great point. We view this technology as the ability to augment healthcare or to supplement healthcare. So the more time is spent with a technology to do screening, then we as individuals don't have to do that anymore. And we can actually spend more time discussing the patients and their day-to-day lives and how their various health conditions has impacted not only the patient, but their family. And so this technology actually allows us to streamline and improve healthcare and improve connectivity between the healthcare provider and the patient and their families.
Dr. Fried, every corporation in the world has been forced to move to digital platforms. Has the hospital sector been moving in that direction? I know that a lot of physicians are now doing Zoom appointments. Are there other technologies that have been developed due to the pandemic?
Yes, I think some of the technologies were out there, but they weren't used very much, and we weren't all that familiar with them. I see that the technology has really taken us in 3 directions. One is it's allowed us to take care of patients at home using technology that we had not used very much before. And if you think about it, it's a natural extension of the way we take care of patients after surgery. Nowadays, we operate with minimally invasive surgery. Rather than people recovering in the hospital, they're recovering at home. So we're now getting educated through these technologies that we're using to interact with patients during COVID to better manage patients during their recovery at home that will be much more durable.
Can you give us an example?
Sure. I think that we are now doing operations on the stomach or esophagus as day surgery. The patients are going home. If they would have had complications in the past, infection, bleeding or something, they would be in front of us. But now we're using apps and wearables and things like Dr. Sharma talked about in the management of these people. It allows us to manage them, but also to capture data so that we could start to see whether a patient is recovering according to a trajectory or a pathway that we would predict them to recover. But if they're not, to be able to identify that they're not doing well earlier in their course, bring them in, have an in-person visit, and try to interact with them before a complication occurs. And therefore, I think that this is a lesson, this is a silver lining of COVID that we're really quite excited about.
How long would a patient have stayed in the hospital before minimally invasive?
Weeks. You can imagine a chest operation or a major abdominal operation, 7 to 10 days would be common. And now some of them are going home the day of surgery. We're doing lung cancer surgery. Patients are going home same day in selected cases. Esophageal surgery, stomach surgery. We've even done some colon cancer surgery and had patients go home the same day. So it's like COVID that we were doing before, in fact. Patients were being managed at home.
Now, do you think that these advances, especially the Zoom appointments, is this going to be here to stay after the pandemic?
I think that Zoom or these types of interactions are efficient. They're better for the patient. They're particularly useful once you've already established a relationship with someone. so that you know them, they know you, and you have trust. But there are other technologies that I think are even more powerful than Zoom. There's technology that's homegrown from Quebec called REACTS, which allows you to do augmented reality. You could almost take your hand on the patients in a very secure fashion and show them how to do various things. You could imagine someone that may have a stoma, like a colostomy or something. You could teach them how to manage them and manage their problems using this type of technology that's even stronger and more powerful than Zoom. This will stay.
That sounds terrifying to me as a patient. Do you think that the response will be positive from your patients?
I think you have to select the patients. You have to know their familiarity and comfort with technology. And as I said earlier, it's very important that you have a relationship of trust with them and that you know the patients, you know what you could do remotely, what you should do in person. And you should always make the patient feel that they're comfortable about coming in for an in-person encounter if they don't feel comfortable doing this remotely. But for many people, it's much more efficient, it's cost-effective, and I believe that for a selected group of people, this will be a durable change in the way we manage our patients.
Briefly, Dr. Sharma, should we be all running to the store and buying these home monitoring devices and bring you the results?
Well, I think it very much depends, on the condition and the type of patient and the trust and rapport that you have with them. I think a lot of these technologies can be very helpful, but they do need to be tested, and that's what we're doing here. So, for example, with the Amazon Alexa, which was built in collaboration with AWS or Amazon Web Services, we are testing the utility of these technologies. So I think before everyone goes out to buy them, we need to make sure that we're doing the right thing and testing these technologies to make sure that they work, that they measure what they're supposed to measure, and that people are comfortable and they trust using these devices.
Dr. Sharma, you had worked with Mila in Montreal on developing a contact tracing app for COVID-19. Can you tell us about it, and what happened to that app?
Yeah, so contact tracing is a concept in infectious disease where if one individual is infected and if that person has had contact with multiple people, it's about identifying who they are and intervening appropriately, either through a therapy or by quarantining in the case of COVID, to prevent further spread of the virus. Now, contact tracing is quite challenging, especially with the current coronavirus, in that it spreads very quickly and multiple people can get infected fairly rapidly, even with minimal contact. As a result, there were a number of analyses that suggested that using digital applications and using GPS and Bluetooth on the applications can help to rapidly identify when one person has potentially been in contact with someone else who has COVID-19 or the symptoms of the virus. And so that individual can then take appropriate actions, either to quarantine or get tested or speak to their healthcare provider. So I was working on an application with Mila that focused on the use of artificial intelligence and how artificial intelligence can augment and accelerate this contact tracing. We were in a number of discussions, and the government has now decided to go with a more simpler sort of binary contact tracing application, but we are actually very pleased that this technology is being considered and is being used. It has been launched in a number of countries across the world, and the preliminary evidence suggests that using these types of digital technologies can really minimize the spread of COVID-19. And we're excited to see the launch of the new application that will happen through the federal government in the future.
Now, is that the future of medicine? Should I be expecting that my phone will be tracking all viruses surrounding me and I'll be alerted whenever? And also, I'm worried as a patient that my every move is being tracked by the government. Is that the future?
That's a great question, and a lot of people have that as concerns in terms of what is the balance between public health and the ability to treat a population and personal agency and privacy. And these are things that we struggled with when we were discussing some of these issues. I think a lot of it depends on the circumstance and the pandemic and the types of viruses that we're dealing with. In the case of COVID-19, from a lot of the apps that are out there, it's very privacy forward, where we are not tracking, or the government and other applications are not tracking the individual's location, but only if you've had contact with someone. And so I do agree that it is of concern in terms of personal privacy. There needs to be a lot of transparency with regards to how these applications are developed. And I think individuals need to develop trust and to hopefully the federal governments and other governments actually can educate individuals as to how these technologies work, what is it tracking, and what is it doing.
Dr. Fried, we hear so much about artificial intelligence and how it's going to completely disrupt medicine. Can you explain to us why? What does that really mean to us? I know you're doing a lot of work in this sector.
Artificial intelligence is a technology that allows us to utilize data in a more efficient way, to do analysis of large sets of data. And so it's a very general term. How it's going to be used is, we're still in the infancy. I'm very interested in its role in surgery, in the ability to provide surgeons real-time alerts if they're about to cause a complication, because image analysis, particularly video image analysis, allows you to train a computer to be able to recognize anatomy. And if you know the anatomy and you know the instruments, you can find a way of predicting if a particular instrument is too close to anatomy that you don't want to injure.
Incredible.
I think that's really exciting. Another example is, as I told you, as we get more and more data of patients during the recovery phase through wearables, apps, inputting data such as pain, then we could start to be able to predict what recovery should look like. And if a person's not following the recovery curve we expect, then it gives us an opportunity to alert the patient, their caregiver, and their healthcare provider to look into that and perhaps to intercede before a complication occurs. That's what people want. Otherwise, our interactions are at various intervals that we say, oh, come back in 3 weeks or 6 weeks. Those intervals are really, they're random. And things don't necessarily wait for an interval to occur. So if you get a continuous flow of data and you could look at how what you're observing matches what you predict should be happening, then I think you could provide better care.
I'm really fascinated by the entire development of new technology, which is the community is not aware of all the work that you're doing. I've heard that you are also running an innovation program to try and matching business and engineers with hospital physicians. Is that happening?
This is true. So we've been doing research for a long time, and we have an excellent track record. And that allows us to create knowledge, new knowledge. But the goal of innovation is to be able to take that knowledge and utilize it and to scale it in a larger way. So what we want to do is to take the knowledge created by clinicians and merge that with the skills of engineers and the business sense of business people. So we started a graduate program, a master's in experimental surgery with a concentration in innovation several years ago, and that has grown every year. Now it's grown beyond surgery to all clinical specialties. And the way we do that is we create a team of a clinician, a team of engineers, usually a computer scientist, an electrical engineer, mechanical engineer, a materials scientist, and an MBA student. And they observe in the hospital setting, they identify unmet clinical needs, and they come up with solutions. And we are training them to be entrepreneurial, how to protect their intellectual property, how to go about and raise funds for it. And our goal through this is twofold. One is to provide better, timely care for our patients, but the other is to be able to generate revenue that will go back to our institution through the foundation, I hope, to help be the engine for further discovery as we move forward.
What do we need to get done to do that? Because, of course, Montrealers want discoveries to remain here. Many great discoveries have been made in this province with no revenue coming back, and I believe Listerine is a great example of that. So what do we need to do to be able to keep that investment here in the city?
I believe that we need to train people to be entrepreneurial. We have to be able to train clinicians when they have a good idea to be able to take it to the next level, not to just park it aside because they're so busy with their clinical work. We need to have our community be able to come behind us and support through early stage funding, ultimately to create a critical mass of expertise that will help build a community of entrepreneurs within Montreal and attract entrepreneurs from elsewhere as a magnet to want to work in Montreal, to be able to succeed in bringing these new ideas to the community in a very structured and rigorous way.
Can you explain to us, are you allowed to share any of the discoveries that the group has created?
Well, we have a number of early stage discoveries. They're not yet at the stage where I feel comfortable divulging the technology, but they are in a variety of areas, such as 3D printed new hip replacements, technology to improve the optics of scopes that we use in patients. As I said earlier, artificial intelligence to track our patients when they go home through apps and wearables. So there are a number of these ideas.
Dr. Sharma, you are doing a lot of work with artificial intelligence. Can you tell us about any of the projects that you have ongoing?
Sure, Julie. So one of the projects that we have going is trying to use artificial intelligence to improve the identification and diagnoses of chronic diseases that can really adversely impact patients and individuals. One example is diabetes. So diabetes is the #1 cause of kidney disease in North America, in addition to amputations, eye disease, and it's a big risk factor for the development of heart failure and other cardiovascular illnesses. The problem is that diabetes is not often diagnosed very early on, and sometimes individuals only pick it up once they've had something happen, such as a heart attack or heart failure. So my team and I have developed various algorithms to use ECGs, so electrocardiograms, to help screen for diabetes. ECGs, if any of you have had it before, are when stickers are put on your chest and electrical recordings are created out of your heart. They can be done in any clinic, and it's usually done to diagnose cardiac conditions. But there's actually subtle changes in the ECGs that occur when individuals have chronic diseases, such as diabetes. So we've now used deep learning in order to help us screen all of these ECGs and flag those for individuals who may be at higher risk of diabetes. You can imagine this can be implemented across all these devices, across every clinic in Canada, for example. And what we've also done is validated this using single leads, which is very important because the next generation of watches that are going to be coming out can give you a single lead ECG. So now even at a community and population level, we can think about how we can use wearable devices to screen for chronic illnesses. And this will allow for earlier intervention and earlier treatment. So those are some of the one project of artificial intelligence that we're using right now.
So what does that mean for me as a patient? If you screen and identify that I am at higher risk, does that mean just years in addition of medication?
Well, it depends on what we find. A lot of times, individuals can intervene through lifestyle, through changes in diet, through interactions with their healthcare provider to take non-medical approaches to prevent onset of diabetes and prevent illnesses from developing. And we believe that these types of technologies can identify individuals far earlier in their course so that they can be initiated on the appropriate strategies, whether it's non-medical or medical as well. So we're very excited about this, and our studies are currently underway to validate a lot of the findings that we've had.
Now, both of you have been talking a lot about very high-tech technology, yet I can book an online appointment at my spa and I can do the same at my gym, but I still can't do that in a hospital. So are we going to be able to resolve those basic questions in the near future?
Great point. And I think a lot of that emphasis on patient-centric and human-centric care is really coming to the forefront, especially in the current pandemic. The ability to book appointments, the ability to have medications delivered to you, the ability to have care delivered in your home are all things that are being driven by this pandemic. And I think we'll be seeing more and more of that in the future.
Fantastic. Dr. Fried, I'd like to turn it over to you. Now, you have been in medicine for how long? I'm putting you on the spot.
40 years, yeah.
40 years. You have developed incredible technology. You've really been at the forefront. What is your next big dream for surgery and for medicine?
Well, I have a dream locally, and I have a dream, I guess, that extends beyond local. Locally, we live in a fantastic environment in Montreal. If you think about what's around us, we are a hub for artificial intelligence. We are a hub for the aviation industry, logistics. We have so much talent around us that the gaming industry is another example. What I would love to see is better integration of all this technology around us, around the patient and healthcare, and to build these types of bridges and partnerships so that we can learn from one another, and I believe we can, that will make our city really attractive as a modern city with healthcare that has no peer. I see it at the hospital level that we need an environment where we can safely introduce new technology, and also to bring non-healthcare people into a clinical environment, because they see things differently than us. When you watch an engineer as they observe a clinical practice, they will stop you and say, there's a safer way to do this. And we've often just continued to use the techniques we've seen over and over again. We have tolerated imperfect solutions.
Can you give us an example?
I'll give you an example. Imagine a lady in labor getting an epidural put in, and the anesthesiologist is telling the resident that you're going to take this big needle and you're going to find the spot between the two vertebrae and you're going to advance the needle. Then there's going to be some resistance, and all of a sudden the resistance is going to give away. Then you stop, you're in the right spot. Now, that's the way we teach people to put in epidurals. But you can imagine an engineer might say that you're putting your major force in the direction where you may cause maximum harm. We've got a thing called a drill. And when you do a drill, you crank it this way, and the needle goes, the drill bit goes the other way. Can we learn from one another? Can we provide an environment which will be open to challenge the traditional way that we do things and come up with solutions that are practical, that we can implement, that can improve the quality and safety of what we do?
So this is a real solution that has been created out of the MUHC?
No, this is not. But this is an example, I think, of the way engineers can think differently and challenge us. And there are these type of aha moments that engineers will stop us and ask us, what are you doing? And we need that.
That's fantastic. And how about you, Dr. Sharma? Do you have a big dream for medicine?
It very much aligns with Dr. Fried here. And so I think a lot of where we're going to be headed is to create a learning environment where new technologies, artificial intelligence, algorithms, devices can be rapidly tested within a local environment in a more controlled setting, and then released to a much more larger population so that we can get real-world evidence of what happens when we release this into a population, but still following these individuals to make sure that we don't pick up some unanticipated consequences. And then once we've shown that this actually improves quality of care, improves patient outcomes, and reduce the cost of the healthcare environment, then to scale this through various innovation labs and through various collaborations, and to expand this across Canada. I think the importance is to make sure we have multidisciplinary teams, whether it's large companies, whether it's small companies, engineers, business. I think all of us have to come together in this learning environment to help move ideas and take them to reality.
Dr. Sharma, Dr. Fried, thank you so much for joining us today. You can visit MUHCfoundation.com to find out more about next week's show. We also hope you will submit your questions and your ideas for our next shows. Thanks for listening. Stay safe.